Endodontic emergency treatment. Endodontic treatment may induce certain emergencies. This emergency will make the patient eager to come to us as soon as possible to relieve his discomfort. Now, dental discomfort may be expressed as pain, and this pain is due to inflammation, release of chemical mediators, and pressure. These things will induce pain. And swelling, which is due to accumulation of pus or tissue exudate. Once the pus is relieved, pain and the swelling will be resolved. Classification of endodontic emergencies. First of all, we can categorize these emergencies according to pre-treatment. First of all, dentine hypersensitivity, and this happens when there is recession of the gingiva and leaving the dentine surface open for any thermal stimulation. It is very easy to heal such a case by dentine desensitizers. Pain of pulpal origin. It may start from simple reversible pulpitis, irreversible pulpitis, acute apical periodontitis. This happens when the infection reaches to the periapical area, and when it increases, it may form acute apical abscess. Traumatic injury. Any trauma to the tooth like this will be an emergency, and the patient will seek help. Cracked tooth syndrome is another emergency whereby the tooth cracks into two fragments, and any movement of the two fragments will induce pain in the pulp. Patients under treatment. Now, when the patient is under treatment, we may experience a mid-treatment flare-up. The patient comes next day of the treatment and tells us that he has experienced pain, which may be due to the previous treatment. Exposure of a pulp when we clean the canal or the cavity, and pulp extirpation is done. This may elicit pain. Fracture of the tooth may do that also. Any recently placed restoration, which may induce pain. And periodontal treatment, when it comes in side by side with the treatment of the endodontic treatment, here there will be a possibility of pain. Post-endodontic treatment. This may happen when we do over-instrumentation. This happens when I'm not very accurate with my working length, and my files enter to the periapical region. This will make a lot of irritation and will make an open apex. This open apex will allow irrigating fluids to go periapically and make a lot of irritation. Overextended obturation like this. Here the gutta-percha and the sealer has extruded a lot in the periapical region. This will make pain. Underfilling of the root canal, leaving space here in the apical region, will make infection because there will be an intrusion of remnants of bacteria and they exudate in this space, and there will be multiplication of bacteria and causing reinfection, therefore pain. Fracture of the root, any tooth that may induce uh, trauma may fracture the root. Of course, fracture of the root depends on where is the fracture, more coronally, in the middle region, and in the apical region. The worst scenario is in the middle region, whereby we cannot save the tooth. When it is more coronally, we can remove the extract or the fractured part, place my screw or fiber post and build it up. In the apical region, we may remove the apical fractured area by pisectomy and leave the rest of the tooth. High restoration, like here, when we place a restoration, for example, composite restoration, and it doesn't, the surface doesn't coincide with my normal occlusion, there will be a premature contact, therefore increase in the pressure on this tooth, therefore eliciting pain. A reversible acute pulpitis, this is very, very common, and this happens when my caries that has induced reversible pulpitis was not treated. The caries enters to the or reaches near to the pulp and eliciting pulpitis. We can see here by the X-ray that there is a gap, therefore it is most likely to be caries near to the pulp. When we remove the filling, the old filling, we can see the reddish area in the pulp, indicating that there is high pressure in the pulp, and when we open the roof of the pulp chamber, there will be extrusion of blood that has been trapped in the pulp chamber. Of course, immediately the patient will feel relief from pain because pressure of this blood will be resolved. The steps of treatment of a reversible acute pulpitis is, first of all, clean the root canal to the working length, place a suitable medicament in the pulp canal, like calcium hydroxide, close the access opening with a temporary filling, check the occlusion, and prescribe a pain analgesic. If the infection extrudes to the periapical region, here it spreads in the spongy bone to form acute apical periodontitis. After that, it will form a granuloma, a cyst, or an abscess. If not treated, the infection will spread to form cellulitis. Acute apical periodontitis. This happens when the bacteria reaches the apical periodontal tissue. Here, this region, the periodontal tissue is very thin and will form acute inflammation, therefore trying to elevate the tooth. That's why the patient feels an elevated tooth. Whenever he bites, he feels that the accused tooth is the only tooth that is contacting. Of course, discomfort on biting and sensitive to any percussion. Whenever we tap on the tooth, the patient will feel pain. Of course, this is due to the spread of inflammatory cells in the bone spaces. We can see here a lot of inflammatory cells around the bone tissue, and this indicates a severe inflammatory condition due to an infection. The steps of management is, first of all, access opening preparation, removal of the pulp tissue, cleaning the root canal, thorough irrigation and dryness. Here it is very important that we do a good dryness, because bacteria will not live in a dry environment, and it will flourish in a wet environment. Placement of intracanal medicament as calcium hydroxide, closing the tooth with a temporary filling. Of course, it's important to relieve occlusion because the tooth is slightly elevated, and prescribe analgesics. Progress of pulpal pathology to the periapical region. Here, it starts with the origin, which is pulpal necrosis. It goes out to the periapical region. It makes acute apical periodontitis. Then this will make a granuloma or an abscess. The granuloma may form a cyst or osteomyelitis. The abscess, which is a collection of pus. Here, there will be maybe a fistula and drainage, and form chronic alveolar abscess, which in turn might make osteomyelitis in the future. It's important to understand that prescribing antibiotics here is not recommended when the area of infection is localized here in the apical periodontal area, acute apical periodontitis. But if there is a spread of infection like cellulitis or osteomyelitis, here it is imperative to give antibiotics. Acute apical or periapical abscess, here we see a clinically swelling is evident with pain and sensation of tooth elevation. This is due to the collection of pus in the apical or in the periapical region. Radiographically, there is evidence of a lesion. Of course, the size of the lesion varies considerably, and there is systemic fever. The steps of management here: we debride the pulp from its contents. We do incision and drainage if the swelling is present. If pus is oozing, the tooth may be left open for 1 day for drainage. Of course, this is controversial, uh, but it may be helpful to make the pressure that's periapically decrease by decreasing the amount of pus that is there. Antibiotics may be prescribed only if systemic features are present, as fever, relieve the tooth out of occlusion, and give analgesics. When the tooth experiences a fracture, whether it is vertical or horizontal, we can see that may be clinically evident, or sometimes the patient comes and says that he has got severe pain, and we see that there's a filling, and this filling doesn't show any signs of a crack. We remove the filling and we may see the crack here. Now, it is incomplete fracture of a tooth with vital pulp. It is commonly seen with teeth with large restorations. As we can see here, these cracks in the root. Of course, pain is experienced when the patient chews laterally, for example, a cotton roll, and this will make the fractured fragments um, move laterally. Therefore, patient will feel pain due to the distension in the pulpal tissue. If my crack or fracture is in the crown, let's say in the enamel, so it's a simple crack. We can do a filling. If it reaches to the dentine, still we have got, the treatment is uh, a filling. If the crack reaches to the pulp, here we need endodontic treatment. But when I've got a vertical fracture way down to the bone, here the possibility of treatment is very limited, and extraction may be the reason, the type of treatment. Steps of treatment. Immediately, we have to reduce the occlusal contact with the cracked area. We analyze the extent of the crack to preserve the pulpal health. If the pulp is involved and the crack is superficial to the alveolar bone, endodontic treatment is necessary. If the crack is below the alveolar bone, extraction of the tooth may be the last resort of treatment. Flare up. Flare up is the occurrence of pain, swelling, or both during the course of root canal treatment. The factors that may contribute to flare ups are, for example, over instrumentation and over obturation. Here, by entering to the periapical region, we may introduce bacteria or foreign bodies that here will make infection, and this will be seen as a flare-up. Inadequate debridement, preoperative pain, percussion sensitivity, and swelling. Any case that before our treatment experiences pain may be expected to increase this pain or swelling after my treatment. One visit endodontic treatment in infected teeth. It is advisable that in necrotic or infected teeth, we do not do one visit endodontics because we need to be sure that our debridement and disinfection is complete and effective. Therefore, we need multiple visits. Periapical extrusion of debris, retreatment. When we do retreatment, we remove old gutta-percha that has some kind of infection. These remote areas may have bacteria that are anaerobic. By removing the gutta-percha and opening the canal, here oxygen will enter and these anaerobic bacteria will be aerobic, and here there will be a serious infection. Apprehensive patients may experience flare up and any history of allergies. Steps of management here is first of all reassurance of the patient. Tell him that this is a normal consequence of treatment. Complete debridement of the root canal. No over instrumentation or extrusion of debris periapically. Establishing drainage if pus is present. Occlusal relief. Use of calcium hydroxide intracanal medication, and we need analgesic and antibiotic prescription.